third one, yeah. We have a pretty similar approach. So I was obliged to talk as a con-speaker. But just to give you a brief summary of what is the primary objective in Harefield at the Brompton site, ECMO, the primary objective is to stabilize the patient for easy recovery or further treatment. Regardless what we need to stabilize the patient in a desperate situation. The second endpoint, of course, is that we would like to have no device failure and, if possible, no or very low complications. So let me show you a typical presentation of a quite dramatic cardiogenic shock ECMO implantation. And you see two operators, one here, and you see some kind of insertion of the cannulas in the femur. You will see later where it took place. But let's go back. And of course, you have seen these publications, the Columbia presentation about the small group is going to be the 15 French, the largest is the 17 French. And if we go through, of course, we know bedside, cath lab, operation room, unknown is a bit funny. But of course, it's a big question. Of course, it's percutaneous, depends on the size. So if you have a small cannula, you're more inclined to do a percutaneous approach. If you have a 17 French, the surgical cut down was the preferred route at that time. What is important, however, where do we insert the ECMO? So, of course, from the Columbia paper, we know it's either the bedside, it's a cath lab, or it's in the theater. Then the question, who is inserting the ECMO? And of course, I'd like to introduce you to three of my charming colleagues. And now I ask you, who's going to be the surgeon? Well, the surgeon's in the middle. It's Hasiba Smile. But of course, we have three different operators who are normally implant an ECMO. It's a critical care consultant, ITU specialist. It's a surgeon or a cardiologist. The question is, when do we insert the ECMO? Of course, well, if in general, cardiac shock patients don't ask, can we do it in the morning, in the afternoon? So we need to distinguish between 8 till, not 5, 9 till 5. We're going to distinguish between 8 in the morning and 6 in the evening through normally working hours for the theater and for our cath lab. Then we have the evening or the night. And last but not least, the weekend and the holidays. And we all know on a weekend and on a holiday, we don't have the full staff in the cath lab. We don't have the full staff in ITU. And we don't have the full staff in theater. The next question is, whom do we need to insert the ECMO? So, of course, we need an operator. And this is independent. If it's a surgeon, critical care doctor, or if it's a cardiologist, we need just one operator. We prefer an assistant. We all know the guide wires are a little bit difficult. You don't want to deal with stability issues. And last but not least, you need a perfusionist to prime and run the ECMO, in particular in Harefield. So if you have a luxury that you can have an ECMO circuit on ITU, but in Harefield, for instance, in the cath lab, in the theater, all over, we only have perfusionists throughout the day. In the nighttime, we need to call them in, and normally it's an activation time of 30 minutes, so you need to wait. So if you have a crash ECMO start, then it's going to be the point that you don't have the luxury, you need to wait for a perfusionist. So let me give you a case presentation. This is a 21-year-old girl who had chest pain on a bus in London beginning of this year. She went to the A&E department to the neighboring hospital. They discovered some ST elevations in the anterior wall. They said, well, let's go to the cath lab. She arrested in the cath lab. They did an angio revealing a spontaneous coronary artery dissection of the left mainstem. And then it was a quite desperate situation because it was an ongoing resuscitation with a Lucas device. They desperately tried to reopen the left mainstem, didn't work out. Then they failed to attempt to insert a femoral ECMO. The femoral artery was Swiss cheese because it really was a desperate. With a Lucas device running, it's not this easy to take, well, can we get an echo machine and ultrasound? Oh, you see, we have a proper, some kind of a positioning. It is very hectic. So they failed. In the end, they called the cardiac surgeon to come in. They did an emergency stenotomy, placed the patient cardiopulmonary bypass, did a Lima LAD graft, and ended up with a central ECMO and an open chest for this young patient. So we come back to Columbia data, and what is important is the bleeding issue. And yes, you say, oh, have a look. If you do a surgical cut down with a larger group, is it 53% to the percutaneous? We don't know if this larger group is really related to the surgical technique. And we all need to be honest. An ECMO, if you have an expert vascular or cardiac surgeon who has done it for a lot of time, you don't find a lot of consultants, attending surgeons, professors who are really doing an ECMO cut down in order to an insertion. More often, it's a trainee who's doing it on site. So we need to distinguish between bleeding complications due to the surgical approach and bleeding complicated because of the size of the cannula. Cannulation site bleeding, there's no question if you have a 17 French cannula, that's more likely to going to bleed. But again, it's a question, is it a cannula or is it going to be the surgical technique when you inserted it? So if we come to the perfect setting, if you have a crash and burn patient, there's no question, you do a percutaneous approach. If you have a cardiogenic shock patient, and of course the question, where is the cardiogenic shock? Is it going to be close to the theater? You have an empty theater, you have a team available, a surgeon available, you get them to the theater and you can do it implant in the theater. If you have a deteriorating patient, rapid, you don't waste time, you do it percutaneously. If you have a slow deteriorating, creeping up with the lactate, you know that it's not going to be good. It's 4 o'clock in the afternoon. Do we want to hope that a miracle is happening overnight? We all know miracles don't happen overnight on ITU. So then it's probably better to consider surgical implant. And then post-cardiotomy, there's no question it's going to be a surgical implant. This is the perfect setting. But what is a reality check? Well, in the reality check, it's all about percutaneous except the post-cardiotomy. Maybe if you're lucky, then you go to the theater. But honestly, it's more than 95% we implant and have it in the cath lab rather than, or ITU bed, rather than in the theater, because we don't have a capacity in theaters throughout the daytime. So now the question, it doesn't matter who inserts the ECMO, he just needs to do the proper way. So training is extremely important. And training is not only identifying the artery with the vein, it's about fixation of the artery and the vein as well. And have a look, this was one of our, I'm not going to tell you who it was. It was not a surgeon who inserted the cannula, but the stitch was, let's say, a little bit suboptimal. And when we expanded this ECMO in theater, we almost decannulated the patient. We all know that this is going to end up in a bloody disaster. So fixation is important. Training of whoever is going to insert it, it's quite critical and crucial. So what is the best case scenario to insert the ECMO? For me, it's till 8 till 4 o'clock. It should be done in the cath lab or in the theater, if you have availability. With the cath lab, you have the opportunity to just check the cannula site with some kind of fluoroscopy. You know, in particular, if you're going to go for the distal perfusion cannula, I personally prefer the cath lab. And then it should be a team. And I prefer a team of either cardiologist, critical care specialist, and a surgeon. Why a surgeon? Because I'll tell you in the surgeon in a moment, because I personally prefer to get the ECMO, in particular if it's longer than 24 hours, not with a closure device, not with a mentor device, because we experience quite a lot of patients with distal emboli, which we need to do an embolectomy afterwards. So coming back to Alain, I'm going to quote one of your papers, one of these key papers, when you beautiful showed that percutaneous approach is really better by means of local infection, critical ischemia of the leg, and bleeding. However, if you add the bleeding requiring surgical revision, that's 9.4%, and you add the 14.7% vascular complication, I opt for a surgical removal of the cannula of the cannulation after weaning of the system. So how to explant the ECMO? The best case scenario, we recommend to do it in the morning. Don't start removing ECMO in the late afternoon, because then you take back the patient to ITU, and you know that you have a limited ITU staff capacity. And if a patient continues to be a little bit wobbly, not really stable, you end up in big, big, big trouble. It should be done, in my understanding, in the theater. A surgeon should do it with a distal embolectomy. And this is a final picture. And Alain, it's your home run. It is the tube station in Paris, where your team successfully implanted an ECMO. And of course, I can't really say con, so let me do it with the British but. So all VA ECMOs patients should be cannulated percutaneously, but if you have a theater available and a team, think about going to the theater. Thank you for your attention.
Thank you very much. Next speaker is also from Brompton. It's Professor Susanna Price, who will tell us something